so people can post in the chat. So first question, when we talk about pathogenesis of perinatal asphyxia, especially related to hypoxic ischemic encephalopathy. So there are, everyone knows that there are two stages where the damage happens: primary energy failure and secondary energy failure. So what is the most important pathogenetic mechanism in secondary energy failure is my question. So you have four options. So first option is failure of cell membrane sodium potassium ATPase, necrotic cell death, release of excitatory amino acids, or impaired cerebral flow autoregulation. So you can post your answers. Yeah, someone has posted. I can see B, C. Okay, we can go to the answer, I think. Most of you have attempted. I think about half of you have answered it correctly also. So the answer is release of excitatory amino acids. And I can see one of the participants has put free radical release. That is also true. But failure of cell membrane sodium potassium ATPase and necrotic cell death, these two are characteristics of primary energy failure. In secondary energy failure, it is excitotoxicity and free radical damage. Impaired autoregulation is mainly a characteristic of preterm babies. Okay, good. I will go to the next question. So whenever we are managing neonate with HIE, it is always told that we should avoid a few factors which can dramatically worsen the prognosis. Like either we should try to avoid them or we should try to identify and treat them as early as possible. Can you name two of such factors? Amber has answered hypothermia, then Karnika, hyperthermia, hypoxia, hypoglycemia, hyperthermia, hypercarbia, hypoglycemia. Okay, many of you have answered. So we'll go to the correct answer. So there are multiple factors, but when we talk about the two most critical factors, they include hypoglycemia and hyperthermia. Okay, and the rest, the remaining factors are actually part of hypoxia, like someone told hypotension, hypoxia, hypercarbia. They come in the definition of perinatal asphyxia. But in the postnatal management, especially during the initial stabilization phase, we should be very wary of hypoglycemia or hyperthermia. If at all they are there, they can dramatically increase the, what will happen? Already there is primary energy failure. Already there is anaerobic metabolism. If there is hypoglycemia, there will be further depletion of ATP. If there is hyperthermia, there will be increase in basal metabolic rate. So both these can result in dramatic worsening of the brain necrosis, neuronal necrosis. Okay. So I will ask a question about preterm neonates, less than 34 weeks gestational age. So what is the typical consequence of hypoxic ischemic encephalopathy in this age group? To these children, like 4 weeks later or 6 to 8 weeks later. Good. So everyone knows the answer. It is periventricular leukomalacia in the short term, and in the long term, it is spastic diplegia. Yeah, good. And it is predominantly due to injury to something we call pre-oligodendrocytes, pre-myelinating oligodendrocytes, which are specifically present in this age group. So beyond 34 weeks, they are actually myelinated and they are partially resistant to damage. Okay. So the next question, simple question: should we give prophylactic antibiotics for all babies with HIE, especially if they are on therapeutic hypothermia? What do most of you practice? Somehow I cannot see the chart. Yeah, false. Okay. Okay, we don't require to give antibiotics for all neonates with HIE. However, whenever there is an indication, we can start the antibiotic therapy. Otherwise, it is not required to be given. Okay. So a neonate with HIE stage 2 is planned for magnetic resonance imaging on day 2 of life. The baby is not receiving hypothermia for some reasons, and the parents wanted some better prognostication, and we are going for imaging as early as day 2 of life. So which additional MRI sequence or software should be used to better delineate the extent of involvement or the lesion? Additional means in addition to T1 and T2 images, what else we should do? Yeah, so answered right, most of you. It is diffusion weighted imaging. MRS is also used, but it may not be as useful as diffusion weighted imaging for the purpose of delineation of the extent of involvement. For that purpose, diffusion weighted imaging is the best. So, an extension of this question: at what age is the routine conventional sequences of T1 and T2 are most they have highest diagnostic accuracy? At what age, if you do? So most studies tell it is around 7 days, 7 plus or minus 2 days. Okay. So at that age, 7 plus or minus 2 days, actually diffusion weighted imaging has a limitation. There is pseudo normalization. So the DWI which is apparent will become pseudo normal, falsely normal at that age. Okay. So of these indications, uh, which of which is the role of amplitude integrated EEG in term units with HIE? The options are: we can use it to decide on need for therapeutic hypothermia, we can use it for prognostication, we can use to detect subclinical seizures, or we can use for all of the above. I think it's a very easy question. Every one of you have answered. Good. So we can use for each and every of these indications. So there are various types of asphyxia you must have read: acute total asphyxia, subacute asphyxia, acute on subacute asphyxia. So when the fetus is subjected to acute total asphyxia, which happens, for example, when there is a cord knot or there is a massive abruption with complete interruption of the blood supply. So which areas of the brain are affected and which areas are spared? You can answer both the questions. posterior limb, internal capsule, subcortical. So you're telling about the areas which are involved? Parasagittal. Basal ganglia. Deep nuclei. Caudopelamic groove. Okay, I will go into the answers. So brainstem, thalamus, basal ganglia. These are the deep gray matter someone has mentioned, along with the brainstem. These are predominantly involved. The important thing is cortex is mostly spared. Even the subcortex is also spared. Okay. So cortex and subcortex and the watershed zone involvement is mostly in the subacute and prolonged insults. Okay. Yeah. So one more true or false question. We restrict fluid intake for all babies on therapeutic hypothermia.
1 minute.
Okay. Everyone has unanimously answered it false. Very good. So we don't need to restrict unless there is an evidence of SIADH. And SIADH usually happens by what age? If it is supposed to, like if it is going to happen, what is the usual age when it will happen after the HIE insult? It doesn't happen in first 24 to 48 hours. That's why we don't need to restrict upfront. It happens usually on day 3 or day 4. We need to monitor, but no upfront restriction. Yeah, good. So someone can answer these basic questions. What is the target temperature? How rapidly we should cool the baby? How rapidly we should rewarm after completion? And what is the duration? Most of you must be having. So this, I think many are not very accurate. So this has to be very accurate actually. So it is 33.5 degrees Celsius of rectal temperature. It's not just 33.5 degrees Celsius. And rewarming, someone has told 0.5 degrees. The range is 0.2 to 0.5. 0.5 is also okay. And we view for 72 hours. And there is nothing like we have to cool as fast as possible. Usually we put on the servo control. It cools within 15 to 30 minutes. So there is no cutoff or restriction for the rapidity of cooling. But rewarming has to be gradual. Okay, everyone please note this because this is very important. So then I will ask you one question about the Helix trial, which most of you would have heard. And it showed that there is significant increase in mortality. In contrast to what the Western data says that there is decrease in mortality and there is no improvement in neurodevelopmental outcomes. So if one of you has read the trial, what is the most striking feature you find which has contributed to these bad outcomes? Ask the question, not visible. You can't see questions?
They're visible. They are visible to me.
Oh, okay,
I think
fine.
only one candidate has written, maybe some technical problem.
Yeah, maybe. So someone can try to answer this question. Maybe slightly difficult question. Unless you read the trial, you may not be able to answer. Increase risk of death before discharge in the intervention group. There is something very striking if you see the baseline characteristics of the population. Developing countries and sick babies. So that is there. LMIC. So it is done in LMIC only. So the most striking thing we found is the outbounds. They accounted for about 70% of the cases. That is not the scenario in most of the hospitals where we give therapeutic hypothermia. We give mostly for the inborn babies, but somehow they selectively chose hospitals where outbounds are being treated. Okay, that's beyond the scope of this discussion, and I will stop here. Oski. Any doubts?